Welcome to another episode of instructional videos brought to you by UCDultrasound.com. I'm Dr. Michael Schick. Today we'll be talking about that gold stuff we care so much about, that stuff that some doctors seem to be obsessed about. And of course, I'm not talking about this, I'm talking about the urine. The urine is more complex than we think, and we can learn a lot about someone's physiology and perhaps pathology by testing their urine. Most commonly, we're looking at whether they have infection or blood in their urine. And if they do, you want to be careful not to splash the stuff in your eye. But in the emergency department and perhaps the primary care setting, what we want from point-of-care ultrasound is a goal-directed question, which is how can we narrow the differential diagnosis of something like flank pain or abdominal pain? The differential diagnosis for flank pain is broad, but using point-of-care ultrasound to look at the kidney for hydronephrosis, and then if indicated, looking for a AAA, and then cholecystitis can rapidly narrow our focus. Now, traditionally, we used to get more non-contrast CTs on these patients. The CT scan has the advantage of diagnosing the size of the stone as well as evaluating for confounding diagnoses. The advantages of ultrasound are that it can be done serially at the bedside, it is a rapid test, and it may avoid unnecessary radiation. An algorithm used by many of us that makes sense is that if you suspect a patient has renal colic, you do a bedside ultrasound. And if you identify hydronephrosis and identify it as severe, you'll get a non-contrast CT and get your urology consults involved. If the hydronephrosis is mild to moderate, you'll treat them clinically. That means giving them antiemetics, antipyretics, and pain medicine, identifying infection in the urine. And if they're improved and can be treated as an outpatient, they can often go home and follow up with urology. If they're not improved, you follow the same algorithm as a severe hydronephrosis patient. If there's no hydronephrosis on your bedside ultrasound, then you need to start thinking about other diagnoses. So you can repeat the ultrasound, you can try a KUB, but that only identifies large stones and is really a poor test for other diagnoses. So you will consider other diagnostic tests. And I'll draw your attention to one more study. This is a recent study. It was multi-center, included a lot of patients. And they randomized patients to point-of-care ultrasound and CT scan for renal colic. And they looked at these patients days out for average pain scores as well as adverse events down the road. And they saw that the adverse events as well as the pain scores was very similar, not significantly different between the groups. And this suggests that you can use point-of-care ultrasound for all patients as an initial test. Some patients will go on to have an adverse event and they may need further imaging, but it didn't make a difference what that initial test was. Renal anatomy is complex, and much of it can be evaluated with ultrasound. If you were to take this coronal cut or long axis of the kidney and evaluate it with ultrasound, and then compare that ultrasound to liver or spleen, the cortex or outside of the kidney would look isoechoic and sometimes hypoechoic. The medulla will typically be hyperechoic, and if the patient has hydronephrosis, which you'll first see at the pelvis and the calyces of the kidney, it will look anechoic or black. The pyramids are typically anechoic but can be hypoechoic compared to the renal columns, which are isoechoic or the same echogenicity as the cortex. Vasculature is anechoic. Now, I know that was a whole lot of terms I just threw at you, so try to look at this still image and identify the anatomy without it being labeled. And then I'll pop up an image of some labeled anatomy next to an anatomical drawing to re-demonstrate that the cortex is isoechoic, the medulla is hyperechoic compared to the cortex. You can see how anechoic the pyramids appear compared to the renal columns. And then just look to see where the pelvis and the calyces are located, because that's where you're really evaluating to identify hydronephrosis. Now, the technique of the exam is relatively simple. You lay the patient supine, use your low frequency or phased array probe. You're going to point that indicator, that little notch on the probe, towards the patient's head. And if you can have the patient raise their arms above their head, that may open up the rib spaces. Now remember that the kidneys are retroperitoneal, they sit very posterior in the abdomen, and so you have to really put your hand all the way down towards the patient's back, often your knuckles are touching the bed. And from here, using the liver and the spleen as acoustic windows to evaluate the kidney in two planes. You want nice images of the longitudinal kidney as well as the transverse. really looking at the pelvis to evaluate for hydronephrosis. If you're having trouble, you can put the patient in a decubitus or a prone position and shoot through the back. As part of this exam, you should evaluate the bladder in two planes as well. You may pick up stones at the UVJ, blood clots within the bladder, as well as masses, and at times hydroureter. Now, hydronephrosis is swelling of the renal pelvis and calyces that occurs when you have a complete or partial obstruction of the urinary system. And we grade hydronephrosis based on its appearance on ultrasound or other imaging modalities. Hydronephrosis can occur from any type of blockage along the urinary tract, which could be an enlarged prostate, masses, or renal calculi. Mild hydronephrosis is defined as mild separation of the renal pelvis with slight prominence of the calyces. It may only be apparent with contralateral comparison of the kidneys. Moderate hydronephrosis is defined as dilation of the renal pelvis and calyceal system without disturbance of the renal cortex. And then, as you might have guessed, severe hydronephrosis is defined as significant dilation of the renal pelvis extending into the medullary pyramids and cortex. Now try identifying the normal anatomy here. These are coronal or long views of the kidney. You see liver on top, spine on the bottom, and there's the kidney right there in the middle. You can see medulla, cortex. There's the cortex right there, and you can see the pyramids along the cortex. Let's look at another example here where you see liver on top, spine on the bottom, kidney in the middle. And you can see that bright or hyperechoic medulla in the middle. The cortex is isoechoic on the outside, and the pyramids as well. One more example, long axis of the kidney. See that bright medulla, and then the cortex isoechoic on the outside. And that's where you look for the pelvis right there in the middle of the medulla. Now look at a short view of the kidney. Here you just see a short slice, and we just scan through it as best we can between the ribs, going cephalad to caudad. When ultrasounding the kidney in the long or short axis, you often can identify the vasculature, which will appear as an anechoic strip coming from the renal pelvis. Knowing where the vasculature is important because that's where you evaluate for hydronephrosis. That's the renal pelvis. And vasculature at times can masquerade as hydronephrosis. Putting color flow and identifying vessels can be very important. Once you've evaluated the kidney in two planes, you go to the bladder and evaluate that in two planes as well. When the bladder is decompressed, it can be challenging to find. You have to point the ultrasound beam very low in the pelvis, searching for urine, which will appear anechoic. If it is a bladder outlet obstruction, then the bladder volume is often very large, and you can measure this volume easily. Now on to some real cases of hydronephrosis. The spleen is at the top of the image and the kidney is underneath, and the anatomy looks normal except for the pelvis of the kidney where there's mild dilation of the ureter and the calyces. This is mild hydronephrosis because there's no intramedullary involvement. Look at one more case here. As we scan through this long axis of the kidney, you can just see a little dilation of the ureter and the calyces at the pelvis of the kidney. As hydronephrosis progresses from mild to moderate, it'll not only involve the ureter and the calyces at the renal pelvis, but you'll see it extend into the kidney. But importantly, it will not disturb the renal cortex. The actual parenchyma of the kidney will appear preserved. So notice how there are many anechoic portions of these kidneys demonstrated here, and they are much larger than typical pyramids. And as you scan through the kidney, you can trace these fluid collections from the distal portions of the kidney down into the renal pelvis and the ureter. Compare that to severe hydronephrosis, where the fluid extends well into the kidney, medulla, and cortex, and seems to be compressing all the structures. The regular architecture of the kidney is just completely destroyed, and it's sometimes difficult to know exactly what you're looking at. You can now understand why the function of the kidney can decrease with prolonged periods of hydronephrosis. This video clip is interesting in that there is severe hydronephrosis as well as a large peripheral renal cyst. We will re-demonstrate cysts in just a few seconds. Urinary calculi can be comprised of many things. However, they are all dense structures that will look very hyperechoic on ultrasound and will often provide a shadow if they are large enough. However, identifying stones is not the main reason we do this ultrasound. It is to rule out hydronephrosis. Renal cysts are a common incidental finding on ultrasound, and they can mimic hydronephrosis as well as a AAA. However, they typically originate from the cortex of the kidney. They are very smooth and typically completely anechoic in the center. And if you scan through in two planes the entire portion of the kidney, it should become clear that these are not originating from the pelvis, but originating from the cortex and are not consistent with hydronephrosis. Unlike benign simple renal cysts, polycystic kidney disease is a real pathological state where you can have multiple cysts throughout the kidney, destroying its architecture and reducing renal function. Now let's bring this all together by watching a real exam being done. A typical position for the patient is supine, with the hand raised above their head to open up the rib interspaces. You should stand at the patient's right with the ultrasound machine on your side. Apply some gel and use the low-frequency probes, either the curvilinear or phased array probes. Apply the transducer to the flank of the patient, typically on the right side first. Point the indicator of the probe towards the patient's head. Your fingers are typically going to be resting right on the bed because of the posterior retroperitoneal position of the kidney. You will interrogate the kidney fully. First start in the long axis, as we show here, and you want to find the mid portion of the kidney, which is typically where the vasculature is or the renal pelvis, and you might see the ureter. Then you want to angle or fan the probe anterior and posterior of the patient just a little bit to interrogate all portions. And then you should slide up and down the cephalad and caudad on the patient around the ribs to get the best images you can for the lower, front, and upper poles of the kidney. Remember, the clinical question we're trying to answer is there hydronephrosis? And if there is, how severe is it? After we're done evaluating the kidney in the long axis, let's transition to the short or transverse axis. Now rotate the probe 9 degrees and point the indicator up towards the patient's belly button or up towards the ceiling. Now we want to interrogate the entire portion of the kidney in the short axis. How we do that is we now angle or fan the probe cephalad and caudad, looking at each pole of the kidney, and we can also move rib spaces, cephalad and caudad as well. We really want to concentrate on the pelvis portion of the kidney because that's where the hydronephrosis will be. Once we are done with the right side, we go to the left side to compare the contralateral kidney. And we're doing this exam the same exact way. We'll look in the long axis as well as the short axis and evaluate all parts of the kidney. You can see that hyperechoic medulla in the center of the kidney, the hypoechoic or isoechoic cortex on the outside. And you can even see some hypoechoic, almost anechoic portions within the cortex. Those are the renal pyramids. We use the same technique on this side, so we fan anterior and posterior in the patient, and we go up and down rib interspaces. Now we will point the indicator towards the patient's umbilicus and get a transverse view of the left kidney. We do the same thing here where we fan cephalad and caudad and move up and down rib interspaces, making sure to interrogate all portions. After both kidneys have been interrogated, we should look at the bladder as well. We place the probe just above the symphysis pubis and point the ultrasound down into the pelvis. And here we identified the bladder. When evaluating the bladder, you want to note if it's decompressed or distended, if there's any obvious mass or clot, and if there's any hydroureter or stones. These typically come in right posterior in the patient. And also you can note if there's any free fluid below the bladder. And we interrogate the bladder the same way we do anything else. We make sure we have adequate depth, adequate gain, and we point the indicator to the patient's right and the patient's head. And this will give us a relative transverse and sagittal view of the bladder. In the transverse view with the indicator towards the patient's right, we'll fan cephalad and caudad to evaluate the entire bladder. And then when the indicator is pointed up towards the patient's head, that'll give us a sagittal view. We'll fan left and right to interrogate the entire bladder as well. And that completes our point of care urinary exam. I hope this was helpful. If you have any questions, we should be putting up a discussion board soon at ucdultrasound.com. Let us know what you think. Let us know if you have any questions. We're happy to put up new content. And as always, scan on.